Welcome to this week's PM&R session on Pediatric PM&R. We have Dr. Christina Aguilar with us, joining us, and also a doctoral candidate, Regina Hurley. Please correct me if I said your name incorrectly. Okay, perfect. We're really excited to have Dr. Aguilar with us. She is the medical director for pediatric rehabilitation medicine at Benioff's in Oakland, and she's also an expert in rehabilitation management in patients with spinal cord injury, polytrauma, brain injuries due to trauma, tumors, vascular surgery, etc. A lot of great things. And we're very excited to have her here with us today. So Dr. Aguilar, if you want to take it away.
Great, thank you. Well, thank you for that wonderful introduction. That was fabulous. Made my day. Happy St. Patrick's Day, everybody. I'm wearing some green. I just put it on for you especially. We're going to have 3 talks here. One will be on pediatric physiatry. That's kind of my favorite topic, but a close second is cerebral palsy. And then Regina Hurley will talk about medical research and applied ontology. Okay, so starting off with pediatric physiatry. So pediatric rehabilitation, what is it? How do you become a physiatrist, not a psychiatrist? And why would you want to do that? These were questions when I started medical school. I couldn't have answered any of them. By the time I finished medical school, I still couldn't answer any of these questions. So you're way ahead of me. I went to a medical school that did not have physiatry, much less pediatric physiatry. And so I ended up taking a very long road. It is one of the UCs, but since you're UCSF, I'm not going to say the UC that I went to. So I admire all of your learning. So the first off is what exactly does a pediatric physiatrist or rehab specialist do? Well, we evaluate, diagnose, treat neuromuscular disorders. And like Liz said, it can include strokes, spinal cord injury, anoxic brain injury at any time, either at birth or later on in life. Burns, working in a burn trauma unit. I did that for a number of years. So and genetic and acquired conditions. Since it's so vast and there's so much to cover, I thought I would just give you one example. So we'll go into cerebral palsy, which I probably see hundreds of kids with cerebral palsy each year. And that is what we're going to emphasize. But this overall subject covers from birth all the way to 21. Sometimes pediatric physiatrists cross over with adults once we get into the 18, 19, 20, 21-year-olds. And sometimes our patients won't leave. They won't go off or be transitioned to an adult physiatrist just because they're more comfortable with the care we give. And the eldest I have treated is 45, and that is definitely pushing my limits. So pediatric physiatrists, usually 0 to 21 years of age, and a number of neuromuscular disorders. Again, acquired, or you could be born with this genetic condition. Now, let's see, going on. So how do you become a pediatric physiatrist? Well, there are a number of routes. You can do a residency and fellowship. You can do residency. You can do a residency fellowship. Sounds like a lot of work. So let's go through it. So the shortest way, let's say you're in a hurry, is 6 years. So you graduate from medical school, and then you do a physical medicine and rehabilitation residency. Normally, those are all adult. There is a smattering of pediatrics in there, but mainly you're dealing with a lot of older people with back pain, older people with some kind of joint injury, arthritis, but you can have, obviously people with stroke, spinal cord injury, and some of that is all applicable to pediatrics. Some of it is not. So then afterwards, you need to do a pediatric fellowship, which is 2 years. And so it would be a 6-year program. With the pediatric fellowship, they often include some research. So that's the shortest way. The longest way, and I put that in red in the far corner so you couldn't see it so well because I don't suggest it, is doing a pediatric or PM&R residency. The PM&R residency would be 4 years. The pediatric would be 3 years. And then the fellowship would be 2 years. So sometimes they give you a little, so that would be 9 years. But most of the time, most programs will give you a little credit for your internship, whatever internship you did. And sometimes you can squeeze it down to 8 years. So in general, it should be 8 years, but definitely not recommended. There's easier ways to go. So this is the way I went, and I hope you can see it. So I started off with a pediatric residency. I had not heard of really physiatry per se, or at least pediatric physiatry, and did my residency, owed a ton of money, and so I had to get out of town. I joined the public health service as a pediatrician and practiced for 3 years on the Navajo reservation. It was really wonderful. It was actually almost 4 years. And I had a great time, paid off my debt, and learned a lot about disabled children, and realized that I didn't know very much about disabled children despite doing my pediatric residency at UCSF. It was shocking that I thought that I was very well trained. I had done very well, but kids with disabilities need a lot more collaboration, discussion with other disciplines, and they're much more complicated than just a routine pneumonia or meningitis or any of the other common things that kids get. I mean, even ear infections, very simple. So I decided I better go back and learn something. And I entered a PM&R residency, which I was hoping to kind of meld my pediatrics into the adult world and pull out what I could from a pediatric standpoint. I finished, and there were no such things as a fellowship, as a pediatric PM&R fellowship at that time. And so I just started putting things together. Since then, there have been a fellowship, but I didn't have to take that. And we have deemed people who do 2 residencies do not have to do that. So you can do a pediatric residency 3 years, get credit for 1 year as a PM&R resident. So the PM&R residency is normally 4 years, but you get 1 year credit. So you come out with 6 years and you're triple boarded. So I am boarded in pediatrics. I am boarded in physical medicine and rehabilitation, and I am boarded in pediatric rehabilitation. So it was a little shorter route, and it's certainly one that I really enjoyed. I enjoyed practicing general pediatrics, but I even more enjoyed the collaboration with the adult group, as well as my collaboration that I have with my current physicians. So So why would somebody go through all that? Why not just do one residency and get it over with and get on with your life? I think being a pediatric physiatrist, it's really opened me up to listening more, learning more, allowed me to do some teaching, but most of all, collaboration. And I am very fortunate, as well as my colleagues, to be part of many multidisciplinary teams, almost too numerous to count. And it is that collaboration with physical therapists, occupational therapists, neurosurgeons, geneticists, neurologists, GI, it goes on and on and on. To give you an example, I had a clinic this morning and there were only 3 patients. They each took an hour and we had collaboration with the physical therapist, with the head of the physical therapy program, the occupational therapy, connections to nurses, social workers, and we made referrals to pediatric neurosurgery, to neuroimaging, and I will be communicating with a pediatrician as well as a GI specialist, all from those just 3 patients. That's all we saw. But the families gained so much, and it's so rewarding to be listening, learning, teaching, but most of all, collaborating with all these disciplines. And once you start doing that, you get this sense of I can really help somebody. I mean, help somebody and guide the help of the team. And it becomes very, very powerful to know that you can do something. It's not like when I was a pediatrician, if you had an ear infection, I give you an antibiotic, you come back and you're happy about it. But anybody can kind of do that. I mean, I don't want to, maybe not anybody, but you could easily do that. That's an easy thing. This is on a huge level. This is on a level of really fine tuning what a child can accomplish and how you can affect their lives and the lives of their family. So continuing on here. So I want to talk about cerebral palsy. Two of the patients I saw this morning had cerebral palsy. One of them did not, but if you met her, you would probably think she did. She actually had a cerebritis late in life, but has a lot of the manifestations. So what I'd like to do now is just switch gears and talk about cerebral palsy, go through a little bit of the definition so we can get all on the same page. Very little history. And then go through classifications, because it's important to try to understand what is going on, and you need to name it in order to actually be able to treat it. And that would include anatomical issues. And then very briefly in the treatment, but I will say the treatment is the most exciting part. And if any of you do have an interest in knowing more about the treatment, I have a lecture for each treatment that I do, and I'm happy to have you come into a clinic where you might see some of these treatments. That's interesting. And again, I always emphasize the multidisciplinary approach. It's not about me. Okay, so the definition, it is, this is an Oxford dictionary, very simple. Impaired muscle coordination. For example, spastic paralysis or other disabilities typical of in the brain. So I think the big thing is that is knowing what's not here in the definition. What's not here in the definition is cognitive issues. It's not necessarily speech issues, not necessarily swallowing issues. It's impaired muscles, but it's very broad. The muscles could be the diaphragm and difficulty with breathing. It could be, the oral pharynx. It could be difficulty with swallowing. It could be a number of things, but these are impaired muscles. When you think of somebody with cerebral palsy, you think of a number of different things that they cannot do or have problems with. But it's actually just a very simple definition. And by definition, it doesn't progress. Although the functional problems with it get worse. So first of all, let's classify it. There's the motor classification, and then there's the functional ability classification. The motor classification has to do with the tone of the muscles, the movement of the muscles, and it depends where that location of the lesion is. The functional ability is just what can you do? So I'm just going to diverge a little bit, but there was a child who was walking around and this has nothing to do with cerebral palsy, but had a little trouble with hearing and vision on one side. And I saw this child and I said, well, let's get an MRI. Never had an MRI. And he's about 4. He was walking. And let's just see what's going on. So we did. And there was very thin cortex. And there was almost very little brain. It was shocking. So despite having very little cortex, good cerebellar area, this person, 4-year-old, was doing all kinds of things. So location of the lesion doesn't always translate to the tone problem and the motor problem, but we're going to assume in this lecture that it does, okay? Because you need to have some kind of framework in order to judge how things are done in the classification field. So function and motor classification can differ greatly, don't usually, but can. So here, I would imagine many of you have seen this. This is the homunculus, the sensory cortex, and the motor cortex. Okay, the sensory in this case is in the blue part, just right behind the motor cortex. Have we lost anybody? Anybody want to ask a question about this? So feel free. Anyway, this motor cortex that we're going to focus on here, because this is a muscle problem. As you can see, there's a very large area with the mouth, and then the hand, okay, and then the leg. All right, and just for reference, this brain is here, but this, can you see my pointer?
Yes, we can.
Oh, okay, good. The ventricles sit here and here, okay, right? I mean, they go all the way through the brain, but they're going to sit right here because we'll come back to it. So going from the homunculus, you go through, this is the cortical spinal tract. There's an anterior and lateral, and you go through the midbrain, okay, with the peduncles and through the pons, and then you get into the medulla and you get the ducusation. Remember the parietal ducusation? Does that bring back memories? Hopefully good memories. And you get the majority goes down the lateral cortical spinal tract. Very few, but some go through the anterior cortical spinal tract. And these fibers, like for example, let's say the legs up here coming down, go through the middle portion, decussate, come on down, and then there'll be a synapses, lots of synapses in here, and out the spinal cord to the skeletal muscle. And this portion from the spinal cord all the way through to the muscle is, this part right here is the lower motor neuron, and this part up here is the upper motor neuron. So have I lost anybody? Hopefully not. So lesions, oops, I moved my thing. Okay, lesions, for example, in the cortex, like if you had a stroke, let's say you had anoxia, then that would bring about spasticity. Spasticity is velocity-dependent movement. If it was in the basal ganglion, which was right about here, let's say the injury is right about here, you are more likely to get a dyskinetic, meaning abnormal kind of movement, not controlled, not spastic, which is velocity dependent, meaning the faster you move the muscle, the more difficult it is going to be, but rather a constant kind of movement, dyskinetic. If it's in the cerebellum, and you know what I realize it's in the posterior part of the brain, you're going to get an ataxic, which fortunately we don't see that much of it anymore. We used to see a lot. Or you could have a diffuse. It could be a little ataxia, a little dyskinesia, and spastic, which is what I saw of one patient this morning. Okay. So the types of movement, tone and movement, have to do, they say there's 4 types, but there's actually more than 4. There's spastic, athetoid, dystonia, and let's see, spastic, athetoid, ataxic, and dystonic. But that's not important because you can get mixtures of them. The most important thing is to try to tease out what is happening with the muscles. Are the muscles stiff when you feel them and you don't move them? Are they stiff? When you move them, are they stiff? Are they moving on their own and you don't have to do anything and you can feel that? Or is it just when they go to move that they have a problem? Try to tease out those things, and that will lead you to the type of CP they have and likely lesion. So in this case, and to be honest, this is not a great slide, but it was the best I could find. The hemiplegia is just one side of the cortex was damaged. The diplegic is, and this is why it's not so good, there's the ventricles that we talked about. They are usually damaged around the ventricles. It's the periventricular leukomalacia that is causing that. And the legs are more involved because remember the homunculus, the legs are more to the center and the arms are out in the periphery. So the legs are more likely to be damaged with this central ventricle than the arms. Quadriplegia is very common with hypoxic events. You have this diffuse destruction of the cortex. Athetoid used to be classical hyperbilirubinemia or kernicterus. Maybe that's too old of a term for you. But the basal ganglia was damaged or is damaged, but unfortunately we don't see that so much. The dystonic ones are more in the thalamus, okay? And the ataxic, there's the cerebellum. Again, it's not the best of pictures of the cerebellum, but it's meaning that you go to move and you're not accurate in your processing of movement. I did make this picture just because I wanted to show the basal ganglion a little bit clear, and then the thalamus as well, just a little clear, because I didn't think this was clear on the other one. Okay, so that is sort of the tone lesion functional, non-functional classification. Now for the functional classification, which to parents is more important. What can their child do given the lesions that are often unchanged, whether it's at birth or whether because you're missing something or whether you had an accident? Where do we go from here? That's what the parents and the families want to know. And so this is created out of that. And it's a gross motor functional classification system, also known as GMFCS. And the highest level is level 1. Pick up a box, walk upstairs, good balance, good coordination. And the most dependent level is the GMFCS 5. Okay, so that is somebody who requires help transferring, requires help with any kind of movement, maybe, well, it's usually not able to self-feed, those kinds of things. And then you have in between the levels 4, which you are sometimes in the wheelchair, but not always in the wheelchair. You can do some walking. And then level 3, which you're independent in your wheelchair. Okay, so you don't have that dependence. You can actually get out and maybe do your own walking. You don't need any help with a walker. Level 3 is one that you'll see that the kids just having a little independence, and the difference between the 3 and 4 is actually much greater in happiness and enjoying life and participating with their friends than the difference between 4 and 5. And then of course there's level 2, which some of these kids in level 2, they can actually, and they work to actually hide their disabilities, and they're not bad at hiding some of them. Quite impressive. Okay, so as we saw, the symptoms vary in cerebral palsy. There's equipment that needs to be used to help improve functional classification. In general, CP does not get worse over time. Well, wait a minute, let me back up. The lesion does not get worse, but the functional requirements may get worse. So even though the motor and tone might be the same, the tone could get worse just because of growth. The muscles can't relax to actually extend the arms. So we can help with those kinds of things. And so now I want to move to the management. And of course, it depends on the functional problems, and it requires a number of different approaches. And we'll go through some of those right now. So therapy embracing. Okay, this is where we like to start, or excuse me, that's where I like to start. Is I like to find out, have they been given a chance to do things? Have they been given a chance to control their head, their trunk, their arms, their legs? And if they haven't, how can I help minimize any kind of further destruction and improve with physical therapy, occupational therapy? So a physiatrist needs to understand what a physical therapist does. And if they don't, well, okay, we better go back to the beginning slides and start over with the years of training. Okay, they missed the boat. So, and they also need to understand where and what to brace, and how and what happens when you brace. I'm just going to give you one little caveat. If the wrists, because I picked that guy, is going like this. It is difficult to make a grasp, and you can try this on your own. It's difficult to make a grasp. If all I do with a brace is straighten out your wrist, then guess what? Feel how much stronger your grip is. And just doing something as simple as that, you have improved the functional ability. Maybe you can now hold on to a walker, therefore you can be independent, and you may be able to even move up a functional ability if I do it, especially if I do it with both wrists. And it is that spasticity that has pulled you into flexion because of the primitive reflexes. So we won't go into the details of the why of that. So just as something as simple as that. But let's say you have that, but you have a dyskinetic, a dystonic meaning rotatory component about the joints. And I don't understand. I didn't take the time to understand what was going on in your wrist. And I brace it. Well, yes, you might have a little better grip, but guess what's going to happen with that dystonia? It's going to move, and it's going to move proximal, and you're going to have trouble with your shoulder or your elbow. So you need to understand what's going on, and you also need to understand what can be done, like therapy and bracing, and what's going to anticipate what's going to happen with such. We can also use the same techniques or same thought process with medications. We use baclofen. It's a GABA analog that, so is tizanidine, to kind of help with the brainstem if the problem is in the upper motor neuron in the brainstem or higher cortex. There are a lot of GABA receptors. If more of the problem is at the muscle level, the dantrium works at the sarcoplasma reticulum at the muscle level. So you would go with dantrium. And Valium, I do not like. It works through the whole cortex. And there's many more, but those are like probably our four. There's a few others that are very commonly used as well. But incorporating them in and understanding what they'll do and how they'll do it is very important. Injections, I do a lot of injections. This mainly is Botox, Dysport, which is a type of botulinum toxin, alcohol, yes, 98% alcohol, or a phenol, which is an alcohol essentially, to destroy the nerve, or in the case of botulinum toxins, to stop the release of acetylcholine into to contract the muscles. So we won't go into too much of that, but once it only lasts a certain amount of time, but once you do that injection and you get that muscle to relax a little bit, then you may be able to put it in a position and allow for more therapy to improve it. So therefore you're working, it's not just give a shot and hope you don't get COVID. It's giving a shot, and then you need to work with that shot, just like you need to work with the medications, just like you need to work with the bracing, just like you need to work with the therapist and everybody else. Surgeries. So I work very closely with lots of neurosurgeons. In fact, all the neurosurgeons in the Bay Area, pediatric neurosurgeons, I know very well. They do intrathecal, some of them do intrathecal baclofen, and some of them do selective dorsal rhizoid. Some of them just do shunts. This is putting baclofen into the spine, and therefore you do it continuously through a pump that you place, and you have to refill this pump anywhere from 6 weeks to could be 6 months. And the medicine is delivered directly to the brain. Selective dorsal rhizotomies, you're cutting sensory nerves. We have a lot of sensory nerves. There's a lot more crossover. It's not just the lateral or anterior cortical spinal tract. You're doing the sensory. It's not that tract that we deal with at all. We're dealing with the cutting the sensory nerves so that you have less stimulation. And that is very effective in decreasing the muscle tone. And then my newest thing is what I'm working on is robotics. I have an exoskeleton and a truxoskeleton. So we take some of these children who've had drastic changes in their bodies by decreasing the tone, changing the motor, and we use a robot to try to improve their functional classifications. And it's just exciting work. It's really exciting work. But I think what I want to emphasize is that pediatric rehab, most of my referrals come from physicians. I think there was 1 year, probably 90% of my referrals come from other physicians. So it's got to be a team approach. You know, physicians aren't sending them out because, you know, just because they want somebody else to see them. It's usually a big problem. And this big problem needs a lot of teamwork. So that's why I like pediatric rehab and try to stay current. So I hope I didn't go too much over time, but I wanted to let Dr. Hurley talk about research and things like that, and then we'll take questions if that's okay. So I will stop sharing my screen.
Yeah, at the top it should say stop share. I can also help you, I think, if that helps.
Okay, yeah, I probably need it. There, thank you. There we go. Great.
Who will be sharing the screen now, Regina?
Yeah.
Hello, sorry. I don't know why my Zoom cut out like as soon as I was probably introduced, but I'm here and yeah, I'll be sharing the screen. 1 second. Let's see here. It's amazing. We've been doing this for a year and I'm still like, wait, how do I share my screen? There it is. Well, okay, so thank you everyone. And thank you, Dr. Aguilar. That was a really nice talk. I'm just here, so as I think was just mentioned, although I was cut out, I am a doctoral candidate at Northwestern University, and I'm just here to talk about something probably none of you have heard of before, which is applied ontologies. If you have, I'd be interested to hear where you've heard of this. But it's essentially something I've been working on recently with some folks who are working in the coronavirus research. It's kind of something that we at Northwestern, a bunch of us got together and started to organize ways in which we could coordinate research across multiple, disciplines, but also institutions. So anyways, essentially, it's just what this talk is going to be a very brief word for anyone who would like to go into pursuing medical research one day. And you might encounter these things called ontologies, which I'll explain in a moment. And so I'm going to talk about, just as an overview, I'll talk about just the general notion of what ontologies are and maybe the specific subset of ontologies that emerge out of the infectious disease ontology, which is what I'm most familiar with. And then, and more specifically, I'll maybe start by talking about how ontologies can help some of the problems that often emerge in trying to coordinate medical research or research generally, actually. So the first problem that often emerges in medical research in particular, but also research generally, is these things called data silos. So data silos are essentially these data stores that are these standalone collections of, huge quantities of information. And if you're ever doing medical research, as I maybe some of you will do one day, you're going to find that lots of other people at other institutions are also doing similar research, whether it's on, cystic fibrosis or immunology or you name it. There are lots of people doing research. And because data collected in, say, a particular hospital or a lab are often annotated in ways that are only locally accessible, which means they can only be accessed by people in that institution with specific language and ways of tagging certain terms. It creates a problem of the inability to share that information with anyone outside of that institution. Or more generally, computer systems that are outside of that institution, if it's just locally stored in a way that's unique to that particular lab, say. So, each one, it's unfortunate that each silo, let's say, may have huge quantities of information that's relevant for the others, but because they don't have a common language, so to speak, they aren't able to communicate in a way that would helpfully transfer that information to the other. I mean, it's much just like a very simple example of, trying to speak with someone who doesn't speak the language you are speaking. You each may have a lot of information that the other one would be glad to know about or needs to know about, but it's very difficult to do when you don't have a shared set of terms. So that's one problem that oftentimes is faced. Another is it can feel like there's almost too much information at times, where information is just from across the globe. And I think the coronavirus, the pandemic, has been an especially maybe exorbitant version of this, where we have research being conducted across the globe in almost every corner on this particular virus that's come about. So it's kind of even more troubling to have this data generated at like very fast-paced rates, and yet to not have a common language that we can use to communicate that information to one another. So anyways, ontologies, as I'll get into in a moment, are trying to find a way to create a common language such that all of the siloed data that happens to emerge out of any individual institution is going to be able to be communicated both verbally, like in literal language like that we speak, but also through computational readings, where the information or the data is able to be read in a common computational language. But anyways, before I get into how potentially this could be solved by ontologies, we need to get a better sense of what is an applied ontology to begin with. So there's essentially two things. The first is that an applied ontology you could think of as kind of like a logically well-defined dictionary. It's a set of terms that both have a textual definition and a logical definition. I might say more about that in a moment. And specifically, an applied ontology it's like a dictionary that contains only terms that are relevant to the particular domain to which it is applied. So, the infectious disease ontology, the one that I'm most familiar with, contains definitions, both textual and logical definitions, of terms that are relevant to infectious diseases generally, like terms like infection or disease course or symptomatic carrier or pathogenesis. All of these terms are present in the infectious disease ontology. Like as I mentioned, the terms have both a textual definition, which I'll share in a moment, is just a plain set of words, like in English for the sake of us English speakers. But then also a logical definition, which includes essentially how that specific term, like infection, relates to all of the other terms throughout the ontology or throughout the dictionary. So here, I'll show just an example of what it might look like. This is just a screenshot from, I think it's actually the the virus and disease ontology, the viral infectious disease ontology. So here you could see that instead of having the words ordered like in a dictionary alphabetically, we don't have V under the category V. We have it rather categorized under a broader category of which a virus can be counted as a type. So a virus is a type of acellular structure. And acellular structure actually is a term that we ended up having to generate because the previous way in which researchers were discussing this, viruses were being almost discussed as organisms, but which I'm sure many of you are familiar with. Viruses aren't organisms in an important way, such that they can't perform any metabolic processes by themselves. They can't really survive without a host. So there are many ways, as you can see, organism is categorized below that, such that we should be categorizing virus as an acellular structure, which is essentially just a structure that has no cells or is not itself a cell. And that's one way in which we were kind of clearing up some confusions in the literature in ways that I think will be made, the importance of which will be made later as I go further down in the discussion. I think I'll also just show you really quickly so as I mentioned, virus is a type of acellular structure, and the structures then there are further several types of viruses, not like specific coronavirus we might say is a type of virus, but these are more general categories of so here we have positive sense single strand RNA virus, and that is the more general category of which, as you can see in our definitions on the way in which we like keep the dictionary straight, so to speak, we have examples of uses of these terms. So coronavirus is an example of what we call a positive sense single strand RNA virus. So you can see the examples there. There are definitions which are written in plain English, as I've said, a virus with genetic material encoded in single strand RNA that can be translated directly into proteins. That's the kind of definition we came up with as ontologists, but also in collaboration with experts like immunologists and virologists, et cetera, and using this kind of process of maybe conceptual analysis, it might be called, which is essentially just of taking a concept like virus or this more specific example, and thinking about what is that thing? What is a virus even? And that is a process by which we think about what ways in which the word is used in the empirical reality, but also like the specific data that comes out of any virology research or something like that. So anyways, that's just an example of what the ontology looks like. And I didn't include the computer definition, so to speak, because it's just essentially like a line of code. So it wouldn't be very interesting, I would think. But that's a crucially important part of ontologies insofar as they are able to be used to translate information in like a journal article to be computer read, so to speak, which is going to enable something called automated reasoning about very important things, actually. So anyways, before I get into that, I'll just share also that not only are the individual terms of a given ontology categorized according to their broader class, so to speak, but also the ontologies themselves are ordered in this kind of nice structure, like it's like the Russian doll thing, the Russian nesting doll thing, where the broadest category I'm familiar with and have been working on is called the infectious disease ontology, which includes all definitions relevant to infectious diseases. But below that is the virus infectious disease ontology, which has more specific definitions regarding viruses and matters related to that. More specific than that is the coronavirus disease ontology, CIDO. And then even more specific, the most recent one that we've been working on is called the COVID-19 infectious disease ontology, which is an ontology related to all of the details and nuances of the coronavirus. And in there, we've labeled all the ways in which the pathogenesis is, apparently according to the literature, is operating, all of the ways in which the virus seems to be mutating and presenting in different ways in different people, different symptoms that are arising in different individuals. That's all incorporated. That nitty gritty stuff is left for the, the COVID-19 IDO ontology, not, placed in the big one. Otherwise that would be quite muddy and large. Here's just, an example of how the ways in which these nesting dolls work. So IDO might have a big definition, like a very broad general definition of what an infectious disorder is. And that has a broad definition, which brings more nuance to, or has brought more nuance in the VIDO ontology, the definitions that are all related to viruses, which likewise has brought more definition in the coronavirus disorder, disease ontology, which is then even more specific when we're talking about the COVID-19 infectious disease ontology, where we're specifically defining what does the SARS-CoV-2 disorder look like. And this way, ontologists are able to create this beautifully well-structured and coherent view of what is happening in all parts, in all levels of any given infectious disease. Here are some examples of the definitions. Maybe I'll pass on reading them aloud because they are somewhat lengthy in some ways. But here's just, if anyone's interested in looking at this, I would invite you to go to ontologies.com, and it's essentially just a huge database, library of sorts that contain all of these dictionaries that range anywhere from a database relevant to anatomy or cell biology, or I think I saw one earlier even on informed consent and different kinds of informed consent in different medical contexts. So it's a really broadly used kind of format. But that's available to the public. So just the last little thing I wanted to say was just a little bit of a word on why applied ontologies are so important. And this goes back to the problems I mentioned earlier that often face researchers. So there's the problem, of course, of data silos, as I mentioned, which is just the fact that information is often gathers in ways that's only locally interpretable. So we can only have people who are, generating that data themselves able to really access it and make good use of it. And then also the fact that there's just so much information, and by virtue of it not being organized in any particular way, it's hard for any individual, one person, to sift through all of it and read, every single article on the coronavirus and try to come up with the implications. And of course, there's going to be relevant information that's kind of completely beside the direct coronavirus research. So we have, trouble kind of pulling all of this huge amount of information together. So anyways, the ways in which ontologies are supposed to be helpful, and in fact have been helpful, is first that they make it kind of, they make existing medical data more accessible to researchers who really need it, because it provides a common vocabulary where it can help the kind of translation problems that exist. And then the other thing is that by virtue of their being logically defined in ways that a computer can read, we can actually tag lots of articles and in a way that a computer can do, like a control find. It can control find, so to speak, all of the terms in the ontology, and then helpfully kind of output some of the information that we might draw from any of the variety of information that we might put in there. And just two examples quickly of the way in which this has been used. So some people I worked with at University of Michigan were able, early on in the coronavirus pandemic, they were able to actually do this kind of they made the COVID-19 ontology. They were able to tag a bunch of the articles that were coming out about the research being done, and they were able to put out a kind of range of potential treatment options that would potentially be helpful by just by virtue of just essentially having a computer read all of the text all at once. And then the last thing I'll mention is more recently, those same people have been have been able to kind of track the ways in which the virus has mutated in a way that is able to use the kind of machine learning and automated reasoning to propose a range of potential vaccine options. So that's just the crash course on ontologies, how they can be helpful. Yeah, if anyone has any questions, I know I want to leave some time at the end. So anyways, thank you for your time.
Perfect. Okay, we're right at 1 o'clock, but does anyone have any questions for either Dr. Aguilar or Regina that they'd like to ask? Hi, Keith.
Hi, Dr. Aguilar. My name's Keith. I'm a first-year PT student. I want to rewind real quick, just make sure I had some clarity. You talked about that, where's my note? Selective dorsal rhizotomy.
Yes.
I was a little confused. Maybe that's a neuroanatomy fail, but I was a little confused on how that removal of the sensory nerves decrease the muscle tone, the motor response.
Right. Well, don't feel bad. When we tell that to parents, they are like, you're going to do what to gain what? So the principle of it is that if you can imagine your hand and you want to grab a glass of water, if you don't know where your hand is in space, you won't be able to do that. If you can't feel your hand, you won't be able to. So the motor, which you saw, the motor and the sensory are so close together that they help with control. And that control is often at the spinal cord level, although they come down, as you saw from the homunculus and the sensory cortex, they come very close together. And the sensory and the motor help with that ability to functionally do those kinds of tasks. So the sensory, when you get rid of a lot of sensory, then you don't have so much crosstalk with the muscles, and that crosstalk, the decrease in the sensory input decreases the reflexes, the reflex arch, that spindle that is a sensory spindle, that decreases, and so therefore you decrease your deep tendon reflexes, you get improved motor control. So think of it as you walked into a concert and it's very loud, and now you want to study calculus, and there's just no way. So what you do is you put on these headphones, and all of a sudden, all you hear is your professor talking about calculus, how wonderful. And that is what it's like.
Okay, so my first thought was then a decrease in proprioception, but is that really more of a refining of
it's actually not the proprioceptive nerves that are cut. It's actually the dorsal. It's actually the light touch that's cut. But the dorsal root is right next to those proprioceptive areas, so it would not surprise me if some of that is interfered with. And this is all done through electrodes. So we're monitoring what is going to be cut before we see what the action is. So we have an action potential that we actually stimulate. We watch, oh yeah, that sensory nerve is really setting off the muscles. We cut that one if it's abnormal.
Thank you.
Sounds like you're very interested. You might want to come to the spasticity clinic. It's the first Friday of every month. And you would also be allowed to attend selective dorsal rhizotomy surgery. If you went through the clinic, it's only half day, and you showed interest, we could get you into the operating room, and you could see some of the things that we're doing.
Oh, thank you. That sounds amazing. I have a huge interest in neuro PT. So,
okay.
Yeah,
first Friday of every month in the morning.
Perfect. Okay. We should probably wrap up now. I know people have class
Sure.
that they need to
Good
get
luck.
to in about 5 minutes, but thank you so